And welcome to today's seminar on innovating in the health sector in India. I am Sanjay Kumar, the India Country Director of the Lakshmi Mittal and Family South Asia Institute at Harvard University. The mission of the institute is to engage through interdisciplinary research to advance and deepen the understanding of critical issues relevant to South Asia and its relationship with the world. As part of this engagement, the Mittal Institute hosts a multitude of events covering topics in the arts, humanities, sciences, education, business, and more. We are so glad you joined us today, and please consider joining us for our upcoming seminars. A couple of housekeeping items for today. Today's session will be recorded. During the Q&A session, you can submit questions directly to moderator via the Q&A function on Zoom. Due to the large number of attendees at today's seminar, we unfortunately will not be able to cover all the questions. Without further ado, I would like to invite Manoj Kumar to deliver the welcome remarks for today's event. Manoj is the co-founder and CEO of Social Alpha, an initiative to strengthen the science and technology startup ecosystem in India with a focus on lab to market enablement. Since its inception in 2016, Social Alpha has nurtured more than 50 mission-driven startups. Manoj is also a senior advisor at Tata Trusts, where he is responsible for managing the innovation portfolio, promoting entrepreneurship, and nurturing the academic R&D relationship globally. Manoj will be handing over to our moderator for today's panel, Vikram Patel. Professor Vikram Patel is the Pershing Square Professor of Global Health in the Blavatnik Institute's Department of Global Health and Social Medicine at Harvard Medical School. He is an adjunct professor and joint director of the Center for Chronic Conditions and Injuries at the Public Health Foundation of India, honorary professor at the London School of Hygiene and Tropical Medicine, where he co-founded the Center for Global Mental Health in 2008, and is a co-founder of Sangat. He is also known for his work on the burden of mental disorders, their association with poverty and social disadvantage, and the use of community resources for the delivery of interventions for their prevention and treatment. He was listed in Time Magazine's 100 Most Influential Persons of the Year in 2015. Thank you for being with us today. And over to you, Manoj. Thank you.
Thank you, Sanjay. And good morning, good evening, all the participants and panel members. I welcome you to this seminar conducted by Mittal Institute, and I'm representing Tata Trust and Social Alpha here. Tata Trust relationship with Mittal Institute has been more than 5-year-old. The whole idea started with Professor Tarun Khanna's initiative, where he wanted to create a cross-border research ecosystem where researchers from US universities and India's larger innovation and entrepreneurial ecosystem could be brought together, and some of the most important areas like education, health, disability, water and sanitation, and climate could be addressed. The idea was to make sure that the research and innovation can be tested and piloted, validated on the ground, and eventually we can find either enterprises, new entrepreneurs, startups, or existing companies who would want to take these innovations to market and communities. This has been a very successful partnership between Tata Trust and earlier South Asia Institute and now Mittal Institute. It has led to several projects across areas like healthcare, water and sanitation, and including projects like soft robotics. We have been, before pandemic hit us about 2 years back, we had been able to do a conference in Harvard, where we brought people from various US universities and our Indian partners together in a physical conference format, which I don't know when something like that would be possible again, considering where we are today. And it has been very successful, and we really created good cross-border bridges. I've got, personally, I've been involved with Sachit in some of the projects, and it has been a great learning experience as well. Working across, academic institutions and our grassroots partners. I hope we get over the current situation, and I'm sure each one of you who has been working on this project is currently struggling to continue these projects or trying to find out new ways of implementing and new ways of working with the partners. But I think we will find out a way to take these projects to their logical results. With that, I just wanted to add one more point, that some of these projects will become very, I would say, ripe and ideal for taking to the next stage. And we need to make sure that within next 12 to 24 months, we can find entrepreneurs who can take over the responsibility for translating these projects into real world solutions. With that, I would like to hand over to Professor Vikram Patel to conduct the panel discussion. Thank you very much for listening to me.
Thank you very much, Manoj. I know you've been struggling with a bit of a cold, so I want to express my appreciation that you were able to join us today. Before we start with the panel, I know I speak for everyone here in the Harvard community to reach out to all our friends and colleagues in India. We have been watching with horror, really, what is happening in India right now, and we wish you, your friends, your family, loved ones safety in the really difficult weeks that lie ahead. Of course, the timing of this seminar could not have ever predicted the situation that India finds itself in right now, and inevitably we are going to pivot some of our conversations today as to what can be and should be done in India during the weeks ahead and perhaps even beyond. As you heard from Sanjay, there's a long history of a collaboration between the Tata Trusts and the Mittal Institute, and today's this panel will focus on one particular area of that collaboration, which is healthcare. Research and innovations in the health sector are really focused primarily on technology infusions, process improvements, widening the coverage and range of services offered, and really reimagining the mode of healthcare delivery. And we're really delighted that we will have examples of each of these being heard today. Much of this work has been carried out in partnership with actually quite a broad range of institutions, the traditional government and academic institutions, but also NGOs, civil society groups, and other foundations, and have involved partnership between a range of experts from the US, across the US, in fact, and India. So today we're especially pleased to be joined by the principal investigators of 3 health-focused projects who I'll introduce when I invite them to come and give their opening remarks, Sachit Balsari, Pawan Sinha, and Anand Bhan, who will speak about their research, the policy work, the prototypes they're currently developing, and what their aspirations are for the future of this work. But we're especially pleased also to welcome to this event a very special guest, Rajni Ved, who will speak about the role that governments can play in encouraging these healthcare innovations and scale up. The structure of this event is as such. I'm going to invite each of our 4 panelists to give opening remarks, which are prepared remarks regarding the work that they are doing. Then we will have an open Q&A, and I would really encourage those of you who have any questions, please do use the Q&A box, and we will try and attend to as many as we can with the time that's available. So let me move on to inviting our first panelist, Dr. Sachit Balsari, who is the principal investigator on the project on power-shifting technology and training in healthcare. Sachit is an assistant professor in emergency medicine at Harvard Medical School and the Beth Israel Deaconess Medical Center. Since 2009, he has been affiliated with the FXP Center for Health and Human Rights at Harvard University, where his research has contributed to advocacy on behalf of vulnerable populations affected by disasters and humanitarian crises. Sachit, welcome.
Thank you, Vikram. Thank you, Sanjay and Manoj, especially to the Tata Trusts for this very long and sustained support that has helped a lot of researchers, both in India as well as Harvard to jumpstart the vision, Manoj, that you had outlined. Diving directly into our project, task shifting technology and training. I hark back to the launch of the iPhone in 2007 that marked the beginning of the mHealth revolution around the world. The power of the personal computer in the next 5 years or so after then was set to become extremely portable, and the growing penetration of cell phone coverage allowed the world to imagine a future where mobile devices deployed at the bedside in clinics around the rural developing world would change how, what, who, when, and where healthcare would be provided. Despite billions of dollars invested in this dream, this was not to be. We received the first pilot Tata Trust grant to test a hypothesis we had developed to examine this question about why there was such rampant pilotitis. These mHealth tools seem to succeed in small targeted communities, but almost never reach scale. The framework was developed to test the successful integration of digital health tools. And our hypothesis was that it required 3 pillars: task shifting, technology, and training. India did not, will not, and need not have the human resources to staff every primary care clinic with an MBBS doctor trained for 5.5 years. The vast majority of ailments that patients come to in clinics anywhere in the world can usually be taken care of by mid-level providers by following standardized protocols. Patients in the United States are routinely given care by nurse practitioners. India has long-standing success with community health workers chipping away at tasks that were originally the purview of allopathic physicians. Heavily contested court cases in Maharashtra have ruled in favor of community health workers, even giving antibiotics to mothers or children for very specific conditions. In the early decades of the 21st century, information and mobile technology have the opportunity to accelerate this transition manifold. Take, for example, the protocol for chest pain in a tertiary hospital in New York City. A 40-year-old patient presenting with chest pain with no risk factors is offered 2 blood tests, the cardiac troponin 4 hours apart, and 2 EKGs 30 hours apart. If all the tests are normal, the patient goes home. Think about the same scenario in primary care clinics anywhere in the world, especially in resource-constrained settings, where either the unfortunate patient, a patient will be given a potion by a quack, or if they present in front of a registered practitioner, they're likely to be referred to the next higher level of care that can sometimes be as many as 8 to 12 hours away. There's no need for this to happen. Troponin is now a point of care device that is available at the bedside. EKGs can be done portably and can be read remotely by a cardiologist sitting miles away. What does not happen is an overlap in this Venn diagram of understanding what the real world needs are, what the standard of care is globally, and what technologies are available that can fill this gap. On the flip side, where context is understood, limited experience with design thinking has precluded widely deployed digital health platforms from reaching their full potential. Public health screening tools, for example, replicate the analog world, generating endless pages of radio buttons for community health workers to click through, with reams of data generated that do not necessarily see the light of day. Lack of standardization, interoperability, and mandate have generated vast streams of siloed data across vertical programs in the global south, and especially in India. An exploration we did with Tata Trusts, for instance, early in this project, we examined existing data flows in one primary care clinic in Maharashtra, and it showed that there were over 3,800 non-distinct data points being collected by community health workers across 171 different forms and registers. It was in this context that we collaborated with St. John's Research Institute in Bangalore towards systematically imagining and building out the ecosystem for integrating technology and task shifting into primary care in India. There was already ample evidence that both task shifting and technology failed to sustain their benefits if not accompanied by periodic training and feedback loops. Where we have landed up 3 years later, including after the pandemic, or the first phase of the pandemic, is a very different place from where we had intended to go. But the flexibility and the generosity of the Tata Trust grants have allowed us to chart the course we took. In the first year of the grant, we conducted a needs assessment in primary care clinics in urban and rural India through observational studies in government-run primary care centers in Bangalore and Ahmedabad and Bangalore, in semi-urban clinics on the outskirts of these cities, and even in the tribal belt of Melghat in Maharashtra, where cell phone penetration and electricity are not reliable. Around the same time, India announced Ayushman Bharat universal health coverage scheme targeting 100 million households of 500 million people. Information technology was expected to be the engine driving the billions of clinical and financial transactions that would follow. In response, at Harvard, we organized a project under the Tata Trust under the India Digital Health Network, with representatives and partnerships with folks from the NCD digital platform in India, Amrit, managed by Piramal Swasth, IM Teco in Gujarat, and technology partners and entrepreneurs from iSpirit and Social Alpha in Bangalore. Before the end of the year, IDHN had provided a substantive 60-page response to the Sri Krishna Commission's data protection bill, focusing on the impact of India's data protection laws and digital healthcare. Our paper, Reimagining Health Data Exchange, essentially laid out the blueprint for what was to then follow from Niti Aayog and the ministries, culminating in the National Digital Health Mission. In year two, we began two work streams, one to start preparing the digital health infrastructure needed to successfully integrate and test these 3T combinations in primary care, and the other to prepare the regulatory and operational infrastructure required to rapidly iterate and systematically test digital health solutions in the public sector for widespread deployment. Our team evaluated ready-to-use open source tools, combining ComCare from ThoughtWorks with ComCare from Damagi with ThoughtWorks' Bamni platform to show what this interoperability was really going to look like in India before we started embarking on this national exchange program. For the second work stream, and this is, I think, what's exciting and lasting beyond the Tata Trust support, is that we collaborated with NHSRC when Dr. Rajni Vaid was still heading it, with Dell Technologies, with Tata Trust, with the government of Karnataka and the government of India, to designate 10 newly minted health and wellness centers in Karnataka as digital health innovation hubs to rapidly iterate and test digital tools that were being provided to the public sector for widespread deployment. This was the ecosystem that would allow this vision that Manoj has of entrepreneurs coming up with these grand solutions, but ones that did not have the opportunity to be tested in a real world environment, especially in our clinics in the public sector. And there was sort of a desperate need for scientific rigor and a testing environment that did not require permission streams going all the way from the village up to Delhi and back, but rapid iterative cycles that allowed both the entrepreneurs as well as the frontline providers to co-develop and co-create these solutions. We essentially were looking in year three, as the pandemic was started, at three key contributions to the digital health ecosystem in India. The inclusion, more specifically, of the term machine readable in the data protection bill, which lays out the stage for health data interoperability, the concept of the personal health record as opposed to a hospital-based electronic medical record that helps to, that then becomes the organizing core for India's digital health ecosystem. And finally, the inclusion of regulatory sandboxes in the National Digital Health Mission that allows for a testing environment for the 3T vision. In year three, we finally pivoted because of the pandemic to apply some of these learnings to telemedicine services at St. John's Research Institution for their patients whose care was interrupted because of COVID. Through the pandemic, we've also secured permissions from a variety of national and state organizations to move ahead with a 3-arm quasi-experimental study. The first product that we will be testing is a non-communicable disease platform developed by the government of India and with Dell. The original intent of the grant was to support the generation of livelihoods in innovative sectors in India. Given the growing and acceptance of the private sector solutions plugging into existing public health platforms, largely driven by technology and interoperability, there is certainly massive potential for growth here, not just in the small slice of the startup ecosystem in Bangalore, but in the creation of whole new cadres of task-shifted providers augmented by technology. In 2021, we partnered with a consortium of technology partners to build a pipeline that will feed new apps and digital tools into these digital health innovation hubs. And we hope to build and sustain this over the foreseeable 24 to 48 months. Thank you, Vikram.
Thank you very much, Sachit. What a fascinating program. And I'm sure there'll be questions about this. And I'm particularly interested in the use of the term pilotitis. And I know that others will also want to hear a little bit more about how you see this work progressing in the future. Let me turn now to our second panelist, and that's Dr. Rajni Ved. Rajni was most recently the executive director of the National Health System Resource Center, which provides technical support to the Government of India's National Health Mission. Her work has focused on linking community processes with health systems and supporting the implementation of comprehensive primary healthcare. From what I know, Rajni is joining us today from New Delhi, and again, I hope everything with your community of friends and colleagues. I hope you're all managing well as can be imagined in this very difficult time. Rajni, can I request you to undo your video and please, oh great, we can see you now. Great.
Thank you very much, Vikram. Well, it's not such a great situation when every 10 minutes you're getting a WhatsApp from friends, family, colleagues saying somebody so-and-so is positive, from 2-year-old to 25-year-olds to 70-year-olds. So it is a very scary situation. But anyway, to this presentation. So let me just share my screen. So my talk today, and is nothing as granular and exciting as Sachit's, but it's basically reflecting from my experiences being at the National Health Systems Resource Center, which is a technical support institution to the National Health Mission, which had a very particular mandate of nurturing innovations in the health system. So I just have a very few slides. I'm making some, basically some reflections from what were the key factors to strengthen the innovation ecosystem, speaking from experience. So I think one of the first factors that drive innovations in health systems are really health system needs and weak performance indicators. So everybody is in search of a solution that would target high neonatal mortality rates, high maternal mortality rates, poor care seeking behaviors. How do you make the lives of community health workers better in terms of ensuring that they get the appropriate support and supervision, in terms of drug kits, etc. So these are really the drivers of innovation from a health systems perspective. The second major learning is that the diversity of contexts in India, and we are particularly fortunate in this, facilitates innovations across multiple contexts that address similar problems. I shouldn't have said interventions, it's similar issues. So if it's neonatal mortality reduction in Maharashtra, in Gadchiroli in Maharashtra, versus in Tamil Nadu versus in Himachal Pradesh, we have a range of innovations being tried out to address similar problems. And this has implications for scaling up because once they've been tested across a variety of contexts, it's easier to take it to scale. The third major point is that strengthening the innovation ecosystem, an important factor is having partnerships between government, academia, NGO, and external funders. And when I say health systems innovations, I don't mean that the innovations come from within the public sector. They could be innovations from any of the stakeholders working on a particular issue. But having a partnership between these various agencies facilitates the process of scaling up, bringing that innovation to light and then scaling it up. I think one of the most important factors that NHM had was fund availability for testing innovations and for scaling up. And it's not very usual for health systems innovations to be, health systems to be provided first with funding to actually test out innovation. So there's a very specific budget line item in the NHM budget that is allocated towards testing innovations. And then if the innovation is successful, there is always support for scaling up. There's another aspect to this, how NHM nurtured innovations, is having a best practice workshop annually. And it's been in place now since 2013. It's a platform to facilitate sharing and learning. It also has enabled the development of specific criteria to review both product innovations as well as process innovations. And I think one of the, since we were part of the people designing the process innovations criteria, two criteria that we were kind of non-negotiable was scalability of the innovation and what was the potential of the innovation for equity. And I think that was very important because of NHM's stated objectivity to provide equitable health services. The second, another set of health systems factors is building capacity of district teams, and decentralization is really critical to foster and nurture innovation. Because you empower district and sub-district practitioners, you build their capacity, they're able to do two things. One, they have the confidence to mount innovations. Two, they're able to recognize innovations that happen within the district, say at the block level with a service provider, tweaking a particular program to meet the needs of the district. And I'll give you an example. In Navarampur, Orissa, many years ago, where there are mobile medical units to address the needs, health needs of remote rural populations, particularly in tribal districts, a block program manager really hit upon the idea of positioning, mapping out the entire block. And I'm talking of the days when mapping was not really a common thing, about 5 or 6 years ago, and positioning those mobile medical units so that they would be of most help to the really vulnerable communities. Another important factor is having mechanisms for effective interaction with stakeholders. And by stakeholders, I allude to private sector, NGO, academic bodies. Another example for this is when the state of Tamil Nadu, there's a process, now, of course, it's part of the large-scale program, an intervention called STEMI to address ischemic heart disease. Essentially, it focuses on stabilizing patients with any STT wave changes for ischemic heart disease so that they're able to be taken care of and then referred to a higher level institution. This was an innovation developed by a private sector, but the state government collaborated with the private sector and were able to introduce this in all of their district hospitals. And now, of course, it's spreading to several other states as well. Another issue is that innovations in vertical programs or programs that have single outcomes often don't consider the overarching health system. And I'll give you an example. In adolescent health programs, for instance, a long time ago, when they used to be funded by external development partners, always insisted on a lot of additional staff to address the needs of adolescents. All very, very important. We do need counselors, we need staff in adolescent-friendly health clinics, but this doesn't consider how you could translate this innovation into the larger scale health system, where there is often not the luxury of having separate counselors or separate staff for vertical programs. So when innovations are designed for vertical programs or with a single outcome in mind, they also need to consider the overarching health system and what are the implications this innovation would have on that system. Another factor is it's often better, or it's more acceptable, to have a package of innovations that address a similar problem. And I'll give you an example of retaining human resources within the health system, India's constant challenge. So the state of Himachal Pradesh and places in Chhattisgarh, financial incentives to retain doctors have been the solution for a long time. But these particular states took on a composite set of incentives, financial incentives, non-financial incentives, including getting the spouses of service providers jobs to retain them within the health system. And the package of innovations that address a particular problem have a much better chance of scaling up. And finally, I think, and this is my concluding point, is that innovations may need to bide their time. Depending upon the political context, the epidemiological or the demographic situation of a particular context, and the health system's maturity. And again, I'll illustrate this with an example. About 3 or 4 years ago, the Tata Memorial Hospital worked in Thane in Bombay to look at a model where they could train ASHAs to deliver mental health and palliative care. And at that time, there was no way we could have scaled this up into the large-scale health system because the ASHAs were busy doing reproductive and child health. We didn't even think that the ASHAs could be involved in mental health or palliative care. But today, with the introduction of the Ayushman Bharat Health and Wellness Centers and the delivery of comprehensive primary health care, the ASHAs are firmly and squarely within the paradigm of where they're having to deliver some component of mental health and some component of palliative care. So this biding the time is also sometimes innovations just have to wait for their moment. My final slide is on what is the key mechanism to nurture innovation and to support scale up is having the institutional support. I worked in the National Health Systems Resource Center for 11 years, and we are a boundary organization straddling implementation and policy. And we perform the following functions, but I've seen that wherever such institutions exist at the state level, and I have to make the case that we need many more of these kinds of institutions. So what are the functions that an institutional support mechanism to foster innovations needs to undertake? One, identify areas where innovation is needed. So as I said before, what are the drivers of innovation? So which are the problems that really need solving and for which innovation is needed? And then excite people or institutions into actually undertaking innovations in those spaces. The second is to identify innovations when they do occur. As I said before, many innovations happen at the district and sub-district levels, and it's like, it just flourishes there and is never heard of at the state level, much less the national level. So an institution can act that is actually located at the state level could identify local innovations as well. Third, we have to, of course, evaluate the innovation. Innovators are too prone to say that the innovation is successful. This needs an objective evaluation that validates the innovation itself. And an equally important part is the documentation of the innovation. Description. This is important because we're talking about scaling up into large-scale health systems. So model description, the context in which the innovation was located, the cost effectiveness, the comparison of costs between similar models or similar innovations, and most important of all, what are the existing synergies with the system and what might be needed to make the changes in the model to adapt it to a large-scale system. So that skill is necessary. We also then need, beyond the innovation, is to contextualize and design the scaling up strategies, handhold scaling up, and also to evaluate effectiveness of the innovation at scale. And for this, you do need a dedicated institution. It doesn't have to be one single institution. It could be a consortium of institutions. And that's where stakeholders like academia, researchers, NGOs, and the funding agencies come together to build this consortium of innovations, really to nurture an ecosystem for innovation that can be scaled up into large-scale health systems. So that I'll end there.
Thank you very much, Rajni.
Thank you, Vikram.
Thank you, Rajni. Sorry, go on.
I said, I hope I was on time. I hope I didn't exceed my time.
Thank you so much for joining us. And also, I wanted to just emphasize a couple of points that I think we'll return to in the Q&A on the issue of equity, and particularly how you think the health system needs to emphasize this in terms of the inequitable impact that the pandemic is having in India. Let me turn to our third panelist now, Dr. Pawan Sinha, who is the principal investigator of Project Prakash, which is the project that is supported through this collaboration between the Tata Trust and the Mittal Institute. Pawan is a professor of vision and computational neuroscience in the Department of Brain and Cognitive Sciences at MIT. Using a combination of experimental and computational modeling techniques, Pawan's laboratory has focused on the understanding of how the human brain learns to recognize objects through visual experience and how objects are encoded in memory. He's going to tell us more about specifically his work on Project Prakash. Pawan.
Thank you, Vikram. I hope I'm unmuted. Several of you on the call are joining us from India, and I can barely imagine the challenges that you are going through. And I'm especially thankful that you are joining us despite the difficulties that the country is facing. My very best wishes, I want to add to what Vikram had said, best wishes for your safety and for the safety of all of your loved ones. I also want to start by thanking, I'm going to embarrass Sanjay, but I do want to single him out, Sanjay Kumar, the director of the India operations of Harvard South Asia Institute, the LMSAI. Sanjay and his team have been just such amazing supporters of the work that we have done over the past so many years. I can't fully express in words the gratitude that I and the rest of the Prakash team have for him. So let me very briefly tell you a little bit about Project Prakash that Vikram referred to. The health problem that we are trying to tackle is encapsulated in this one startling statistic. About 1 in every 100 Indians is blind. That's across all age groups. across children, the problem is especially acute. The incidence of childhood blindness in India is at least 3 times as high as it is in the West. As if that was not tragic enough, it's also remarkable that a large proportion of the children who are languishing with their blindness don't have to. They have avoidable, preventable, or even treatable conditions, but very few of them actually get treated for the obvious reasons of not being close to a treatment facility, not being aware that the condition is treatable, or simply not having money to get the treatment. And the consequences of this untreated childhood blindness is distressing in the extreme. The lifespan of an Indian child who's born blind is on average 15 years shorter than that of a sighted child. And that's for the lucky ones who are making past the first few years alive. According to the WHO, fewer than half of all children who are born blind live to see their 5th birthday. Very few are educated, and very few find employment as adults. This is the health problem that we are trying to address. The challenges given this problem are, how can we create a program which would include funding and human resources for identifying and treating blind children? How can we improve the state of the art in treatment and rehabilitation? How can we have the program be rooted in the community that seeks to serve and have it be long-lasting? And very practically, from my own parochial perspective, as Vikram mentioned, my lab is a fundamental neuroscience research lab. So how can a basic science lab like mine make headway on these seemingly very applied goals? The innovation in Prakash lies in a very key and a very simple, in hindsight, realization. That realization is this, that in meeting this pressing clinical need of providing treatment to curably blind children, such as this boy, as fundamental neuroscientists, we have an incredible and an unprecedented window into the processes of brain development. So you can imagine a child who has been born blind, in whom you are able to surgically initiate sight. Right from the moment the child's bandages are opened after surgery, you have a window into the process of development in that child, a window that the field of neuroscience has simply not had until this point. So the innovation of our work, of this project, is in meshing together the basic scientific quest and the fundamental clinical mission. Several years ago, we launched Project Prakash to bring together these two goals. And Project Prakash is organized as follows. Our medical outreach seeks to identify children living in remote rural areas to find those who are candidates for treatment. These children are then brought to New Delhi and provided the very best world-class surgical care, followed by education and rehabilitation. This is more of a nascent program. But tied to the treatment and education is our work in basic scientific research. And this is truly a two-way interaction between medical treatment, education, and scientific research. And our hope is that the outcomes would be independence and integration for the children and basic scientific advances. This approach has been bootstrapped with funding from science-oriented organizations. So I posed the question of how do you even get off the ground with such an effort? And because of the science component to this work, we were able to attract funding from organizations like the National Institutes for Health that cater to scientific research, but that funding directly benefits the treatment program, because scientific research cannot proceed in this case without benefiting the children. Project Prakash involves, as I said, outreach. We are based in New Delhi, but our teams go far and wide into the country. These children are then provided high quality surgical care, and then following surgery, we have the research part of the work. Here, as a very quick vignette of what surgery does to a blind child, here is a young child, an 11-year-old little girl by the name of Sumitra, whom you are watching pre-surgically. So at this point, Sumitra just has the ability to see light and dark. She's essentially blind. And we've asked her to try to find a box of chocolates that we've put by the side of the hospital corridor. And of course, Sumitra has a very hard time doing this. That's her father in the background. But next, you will see her about a week after surgery. And you notice just what a remarkable change that surgical intervention brings about. So far, Project Prakash has screened over 40,000 children, provided surgical care to over 500 blind children, all of whom can now see, and provided non-surgical care to many more. The impact of Project Prakash has gone beyond just the children that we've worked with. There have been very significant outcomes, even impacting fields like autism, from the research findings that have emerged from this work. So those are ways in which we are tackling the first two challenges. But I had mentioned that an additional challenge is for us to figure out how can we have the program be rooted in the communities it seeks to serve in order to give it some sense of permanency. And on that front, what we have started doing with very generous support from the Tata Trusts is, instead of just being based in New Delhi, we have recently started 2 satellite centers in the Gorakhpur district, some of the most impoverished parts of Eastern UP. And the Harvard South Asia Institute recently did a very nice article about some of the work that's happening at the Prakash Vision Centers. This, I feel, is just the start. Our goals are very substantial. We want to have a whole network of such Prakash Vision Centers in order to have the care, the critical eye care that's needed in these communities be available to them locally. So let me just summarize. Project Prakash, in the about 15 years of its existence, it has provided us some fundamental insights on the basic science front. It has given us clinically relevant hypotheses about conditions like autism. It is also helping us in the design of artificial intelligence systems. It's serving as the model of an alternative paradigm that can bring together basic scientific research and societal service. And of course, it has helped in a modest way alleviate some of the challenges of childhood blindness in the country. And with that, let me conclude and say thank you to all of our supporters, and especially the South Asia Institute. Thank you.
Thank you, Pawan. Terrific example, really, of how you're going from the bench to the bedside, and from the bedside well beyond that into the population. I'm sure we'll turn back to this issue of the translational pipeline that you've illustrated so beautifully, as how this can also be seen as a critical innovation in improving population health. Let me turn now to our last of the 4 panelists, Dr. Anand Bhan. Anand is a physician who has specialized in the area of bioethics and holds a master's degree from the University of Toronto. He works for Sangat, and he is the head of the Sangat's Bhopal hub. Sangat is one of the leading research organizations in the field of child development and mental health. And I personally have also been associated with Sangat from its founding. He's also a researcher more broadly in the fields of global health, health policy, and bioethics. So Anant, I welcome you to this panel and look forward to your presentation.
Thank you so much, Vikram, and a pleasure to be part of this panel. Thank you also to the Tata Trust and the Mittal Institute for funding some of our work. So for those of you who've been following the panel and might not know of Sangat, Sangat is now 25-year-old and has been working for a long time in many areas, including mental health. And one of our focus geographical areas has been work that we've been doing in Bhopal. And this is work which will sort of speak to some of the insights we've gained from that, and also work we've started to do in Gujarat through the funding from the Tata Trust. So just very quickly, why mental health is an important area to sort of focus on. There's now enough evidence which shows that there's been a historical neglect to global health. Just the fact that 1 in 5 people living globally with depression live in India, yet only less than 10% of those individuals in India receive access to evidence-based mental health interventions. Work by Sangat and many other partner organizations has also demonstrated that evidence-based psychological treatments can be both effective and cost-effective as a first line of care, and these can be delivered by frontline community health workers. We also know that India has among the largest populations of frontline health workers, the ASHAs specifically, but also other cadres, including the newly minted community health officers, who could be leveraged for delivering psychological treatments, especially because psychologists or psychiatrists can be in short supply. Now, some of the groundwork actually came through a grant called Essence, which is funded by the US National Institutes of Mental Health. It's a 5-year study. We are towards the end of the 4th year right now. This is a study we have been doing in Sehor, which is a neighboring district to Bhopal, with an idea of trying to reduce the treatment gap for mental disorders. Particularly for depression, and this is being a work which is being done through an MOU between the National Health Systems Resource Center, which Rajni talked about, and she led till recently, the National Health Mission in MP, and also Sangat. So what exactly are we doing in Essence is basically focusing on developing digital evidence-based psychological therapy training, which could be delivered through a smartphone app. And the smartphone app can also be used offline. We are hoping that this would enable frontline health workers to learn, master, and deliver treatment for adults with depression with an idea of reducing or closing the mental health treatment gap to an extent possible. Of course, you can have an idea, but how do you actually put it into practice is the most important component of any project. And here we have taken a human-centered design, as we call it, which I think was alluded to by some of the other speakers on the panel, where we work with our target population, the frontline health workers, in co-designing our innovation. So this has meant a lot of workshopping, a lot of storyboarding with them, a lot of focus group discussions, testing multiple versions of prototypes so that they are comfortable, they like, and they find it contextually relevant. They are able to understand what the content is, and it is something which doesn't seem foreign to them. It is something which is, again, something that they can relate to. Now, this is work which has taken quite a few months, but has been really substantive in terms of telling us what works and what doesn't work. Now, one of our initial concerns was, would digital training, for example, be something which would be appealing to ASHA workers? Some of who, as you know, have only studied till 8th standard. Sometimes they might not even have done that. But we've recognized and we've realized by interacting with them that this is something that they really have taken to very quickly. There is a fair bit of acceptability to digital training. There is also some level of familiarity now, especially during the pandemic. Also, there's been a lot of uptake of digital technologies among frontline health workers for risk mitigation purposes. But obviously what matters is ensuring that the content and language is something that they can relate to, and figuring out ways to engage them more when you're delivering digital training. So far, what we've done with Essence is actually developed a systematic methodology, some of which I described, to digitize the learning content for an evidence-based psychological treatment, which had already been tested through a manual. We worked with them to co-produce digital content and worked on acceptability, and also looked at competency assessment through the training modules, and also been working on evaluating the feasibility and impact of digital training in randomized controlled studies. In fact, our main study has finished recruitment, and we are just finishing with our last batches of trained health workers, and we should hopefully have some results soon. Now, that led to actually work which has been funded by the Tata Trust and through the Mittal Institute. This is part of a larger initiative called Empower. Empower is based at the Global Mental Health Group in Harvard, which Vikram leads. Empower India specifically is a collaboration between that group and Sangat. And in India, we're trying to use digital platforms in the way we've done in Essence to enable non-specialist health workers such as ASHAs and CHOs to learn evidence-based brief psychological therapies for mental disorders. Through the funding that we've received from the Tata Trust, we have now extended the work we've done in Madhya Pradesh to Gujarat, and we are in the midst of actually testing that out. And what we basically have been doing through this grant is taking that work that we've done in MP and contextualize that for Gujarat. And the reason we've gone to Gujarat is because Gujarat has this large platform called TECO, which almost reaches the entire population, around a 65 million population, and is available all across the state and presents us an opportunity to actually go to scale pretty early if we can demonstrate feasibility, acceptability, and also utility in the local setting. And I will just describe the steps involved in what we have been doing. So the first step actually was taking what we had in Hindi and translating that into Gujarati. So these are the scripts of the Healthy Activity Program, a form of which is basically behavioral activation. We've used, again, the same approach, which is working with local organizations, working with the local experts, as well as our target audience, which is ASHA workers, in ensuring that we get a review done. We have a fidelity check by someone who's an expert, a psychologist typically, in this case, a psychologist who knows Gujarati well, so that we are sticking to the original scripts and we are not deviating when we do the translation. And we do a lot of feedback incorporation through multiple workshops with ASHA workers, with trainers of ASHA workers. And we've realized again through this that there is a lot of richness which comes through, which you can incorporate in the process of improving the content. They also tell us about the fact that this training is relevant to them. They talk about the fact that they have seen such individuals with cases of like depression, but might not have recognized that this is a mental health issue. And the training is helping them reflect on that. Now, once you've done that, what we do is typically go to the studio, we do dubbing, subtitling, and then a lot more workshopping again to try to lock the content for the digital training. This again is then taken back to similar groups of ASHA workers, ASHA facilitators, key trainers of ASHA workers, as well as experts within institutes of mental health who go through the videos, ensure that there is enough fidelity and that we are ready to then launch a training program. Similarly, we've received fairly positive, but also sometimes constructive feedback about what works, what doesn't work, and where there might be a need for more amendments. So where we are now with around 7 months of work in this grant is that we've finished our adaptation, translation, and fidelity check. We have conducted 3 workshops with ASHA workers, nurses, psychiatric social workers, both in the tribal parts of Gujarat, in Jhagadia district, as well as at the Apex Institute of Mental Health in Ahmedabad. And we have now prepared all the videos after all of these checks on 2 platforms. One is our own learning management system in Sangat, and also the TECO platform, which I said earlier covers the whole state. So what we are hoping through this work is that we are using again a rigorous testing approach involving high quality research in testing the utility of digital training for frontline health workers, specifically for delivering depression care. But hopefully this is also work which can impact other forms of mental health care, and also the role of digital remote supports for supervision purposes. We feel that this is going to be an important way, but certainly not the only way, of trying to address the large gap of mental disorders and the need to provide care for that. And especially at times of a pandemic when you might not be able to meet face-to-face, it might provide an opportunity for us to actually get care to local communities. And hopefully the evidence from the work that we're doing in MP and Gujarat will help inform the system-wide scale-up of these training approaches and help again increase coverage for depression care in communities all across India as we adopt more forms of comprehensive primary health care reform through Ayushman Bharat and multiple other modalities. So thank you for the opportunity, and we'd be happy to also connect with any of you who's interested in this domain and provide more information.
Thank you very much, Anand. Can I now request if all the panelists can just open up their video cameras so we can see one another, and we can pivot for the last 20 minutes that we have available for a Q&A. And I wanted to, we've had some very terrific questions, and I don't think we'll have enough time to cover all of them, but I'm going to request all our panelists to be brief in your responses so we can try and take as many as possible. And my first question really is to you, Rajni. I really wanted to hear, all of us want to hear from you about what, as you talked about this, the goal of the NHSRC to strengthen health systems across India. You're facing perhaps the most daunting challenge ever in the history of the NHSRC right now. Could you speak a little bit to how the NHSRC is supporting the government in guiding the COVID response?
Okay, well, disclaimer, I was there 6 months ago, but certainly from the start of last year, Vikram, I talked about innovations being generated within the health system. And over the last 6 months, we've seen some really interesting stuff. A lot of it came from guidance from the central government, but a lot of local innovations happened, whether it was redeployment of human resources within a district so that they could. Human resource shortage is a perennial problem in India, but being able to identify which areas to post with staff so that they could continue to do the essential services, the non-COVID services like immunization, antenatal care, and also be able to do the COVID-related activities like surveillance, risk awareness, contact tracing, etc. Again, it depended upon the system maturity. So we did write guidelines from the national level to say, this is what you should try to continue to do. But at the end, it was empowered districts and states with mature health systems that were able to do this. And I know that for instance, in Tamil Nadu, let me give you an example, where they mobilized the mobile medical units and the ambulances to make sure that people who were on treatment for chronic diseases got their medicines at their doorsteps. That those who were in need of dialysis, they redeployed all of the ambulances that were meant for referral transport of pregnant women to the houses of patients so that they could come in for dialysis. Ensuring that the ASHAs received passes that allowed them to do community level outreach work. Many of these innovations or call it innovations, call it a program intervention, were all directed towards the most vulnerable. So if an ASHA was empowered through online training, as Anand said, and we did experience, we had doubts about whether the ASHAs would take to online training, but surprisingly, a lot of them did. So that was aimed at making sure they reach the last households in the community. And so and I would not dare to say from a national point of view, in a country like India, one cannot say that, but certainly several interventions for essential non-COVID services and for COVID services were aimed at making sure that the vulnerable populations and the marginalized were reached. Now, how successful we were, we already know there's data that we were not terribly successful at doing so, but I must say that there was always this intent at making this happen. And it also led, I think, to rethinking on the way we need to restructure urban health systems so that we have better urban primary health care. I think that was a big learning from this entire experience.
Well, thank you, Rajni. I also welcome, any of the other panelists responding to any of these questions. But as I attempt to try and make the time as efficient as possible, I'm going to turn to another really important question. Manoj, I hope you're still connected with us. I'd like to place this question to both you and Anand. And I think the question really from Dr. Radhika Krishnan is, the role of NGOs, when they develop innovations, how do they actually get supported to scale this up? And I wondered whether, Manoj, you could speak from the perspective of a major funder that has actually been behind the support to many of these innovations. What is the role that you see from a funder's perspective of taking these innovations to scale? And similarly, Anant, what is your view on how NGOs can actually leverage resources? Where do they go to actually take these innovations to scale? So first Manoj and then Anant.
That's a great question, really. But we also need to understand that the philanthropic capital is not unlimited. It's in short supply. And considering we have millions of NGOs in India, it gets very thinly distributed over them. So the real issue is to see the opportunity cost here, right? So if you look at philanthropic organizations and CSR who fund NGOs, they have an opportunity cost, right? And direct implementation for disaster management or COVID care right now versus funding innovation that takes several years to actually get validated, proven, and go to market. So it's really important that, and I noticed this, that every time there is a discussion on innovation, we miss one thing. And even today's discussion, that's big time, I would say gap, that we forget entrepreneurs. And that's something that we are actually trying in Social Alpha to see if we can find entrepreneurs who will take innovations from, lab to market. And that's important, because that's when you can really grow the kitty, the pool, right, that is available for supporting innovation. So just depending upon philanthropic capital for innovations is a very risky and very difficult idea, because most of the time philanthropic capital goes for high priority, high risk areas, and innovation unfortunately is not among them, because it takes time to market is longer. So we need to definitely find philanthropic capital for early stage, like what we are doing with Mittal Institute today. But eventually you need a larger pool of capital to take that innovation to market. So I really doubt an NGO's ability to take innovation from early stage and take it to the communities in a scalable way. It's just not possible.
Thanks, Manoj. I mean, with that somber sort of opinion, I'd love Anant to respond also very specifically to Manoj's challenge.
Yeah, so it is certainly a challenge, but I think in our experience with my Sangat hat on, what has worked has actually been the process of co-ownership. In most of our research projects, we work with the health system locally, and that involves a lot of conversations, right from the beginning when we're doing ideation to proposal submission to working with them to actually set up our projects, work on these projects, because most of our work is around task sharing. It involves working with frontline health workers and the health system. It involves working with various levels of the health system, right from the national level, state level, district level, sub-district level. And it involves working with them to convince them that this is important work, and also for them to support us, because without that support, we can't do those studies. But once we are doing those studies, as the evidence is getting generated, it's also important to feed that back into the system and tell them that, this is what we've learned, this is what seems to work, this is what might not be working, and work with them to try to advocate for policy change. Sometimes it works, sometimes you might not have as much success. With Rajni, for example, we worked in trying to integrate PHQ2 into the revised comprehensive CBAC form, which ASHAs use. And I think that's a small win, but that tells us that these wins are important, but they have to be based in evidence, and evidence ideally generated locally, because that is the kind of evidence which has the most impact. So I think policy impact is important, and NGOs can work on that, but you cannot work in islands of isolation. You have to work with the system to bring about that change.
Absolutely.
Thanks a lot, Anant. I want to now turn to Pawan and Sachit to address the question that I think is really, really interesting from Sonalini Mirchandani, and I'll read out the question. Is scalability necessarily always a desired criterion for acceptance of an innovation? I think it's a very challenging question, because we always talk of scalability as the ultimate goal. And she argues sometimes scalability needn't be in the terms of physical or geographic extendability, but in the context of deepening or strengthening a process. For example, community-led interventions have their own dynamics and are situated in very specific contexts. These may not be scalable in the traditional sense of the word. Pawan, first to you, given your work is, it's a great example of that actually, and then across to you, Sachit, after that.
Thank you, Vikram, and thank you, Mrinalini, for that question. So I completely agree that the way one defines scalability has to be nuanced. In Project Prakash, scalability can be thought of as the impact that you have in terms of the knowledge that you generate. But the other more conventional dimension or definition of scalability would be how many people on the ground are you positively impacting in the short term. And we have been trying to walk this fine line that that balances both of these definitions of scalability. We would have been happy with just one, say the service or the science side, but I think there is a happy medium to be found. You can have, I mean, we feel obligated to have primary eye care be made accessible to as many people as possible, because all of our groundwork so far has shown us just how pressing the need is. So it just seems right for us to try to scale our presence on the ground. And that's why our desire to grow the network of the Prakash Vision Centers. But at the same time, we also take to heart the point that the knowledge that's being generated from the scientific work that has its own way of scaling up, has its own way of having an impact on the scientific community, and also when it's translated, then on the clinical side of the world as well.
Thank you, Pavan. Sajid?
So yes, Sonalini, you're right. Scalability should not be the only metric, as Pavan said. I wonder if sustainability and memorialization are equally important. The trouble with these pilots is twofold. Both successes and failures are not memorialized and not institutionalized. In the very specific Indian context, given the high turnover of bureaucrats in the health and public health departments, often you would have really good innovations. Sometimes with the private sector, you've gone through this checklist that Anand was talking about, co-creation, co-development. Two ideas here at the Harvard Mittal Institute were engagements at the Kumbh Mela in Haridwar, in Allahabad and in Nasik, where with partners in India, we had set up very light touch, real-time disease surveillance systems all the way back in 2013. And not only does it not scale, though that would have been desirable, but there is no institutional memory embedded in the public sector of these initiatives, which precluded its rapid deployment during the pandemic, where a very simple solution deployed across all primary care centers would have immediately allowed the setting up of a national epidemiological disease surveillance system at very low cost and very high speed. And that is the trouble. So I think scalability is probably the second or the third step. We need to figure out how to take these pilots, and even when they're successful, find the regulatory and the financial resources required to continue to then go beyond the experimental stage.
Thank you, Sachin. All right, I think we have time for one more question, and I'm going to keep this an open question for pretty much anyone on the panel. And it's another very interesting and a very, very, very lively question in India right now. And I'll read it. I'll excerpt it. It's from Bhaswati Bhattacharya. The question is, where is the role of Ayurveda amongst all of these efforts? And I guess one should look beyond just your efforts more generally, but more particularly about the role of Ayurveda in innovation. Bhaswati goes on, not only is the current government supportive of this knowledge, but there's plenty of evidence to show lower cost interventions that could be useful for people, for patients, and implementable by open-minded medical people. Maybe I'll throw this open. Would anyone like to field this question? It's, I think, a very germane question given the context of the support that Indian Sisters of Medicine are receiving currently.
So I'm happy to maybe make a small comment to this. So in line with what a lot of us have been trying, there is actually, as Manoj was talking about, a whole new set of entrepreneurs in even the Ayush space, specifically allopathy, who are very interested in using an evidence-based approach to this problem, which is to say that they recognize the importance of building the evidence to make the case that certain interventions have promise. They are trained to recognize both the utility of evidence-based approaches as well as understand the richness of Ayurveda and then are making the case through working through well-established research protocols in establishing that. And I think that's where we can see a lot of new information, new evidence coming in, because I think there is certainly a lot of interest in that space, but there is also skepticism, and the way to address that skepticism is to generate evidence. And I think that is the role of research institutions, that is the role of entrepreneurs, is to actually generate that evidence so that we can leverage all of these existing knowledge bases, the rich literature, and actually demonstrate any impact, especially from a health systems perspective.
Okay, thank you. Well, I want to now ask a question to all of you. As much as you're able to respond, please feel free to do so. And the question is this: if you had the year of the health minister or the prime minister of India asking you to give a recommendation on how the country can actually stem this horror that is unfolding, what would you suggest is the most immediate and urgent action the government should take? Let me start with you, Rajni, since you have been closest to government in these last many years.
Yeah, and thereby perjure myself. I'm still an advisor to the ministry, Vikram, you're putting me on the spot. You're going to ask someone else this, please.
Okay, all right. Let me start. And let anyone who wants to get going. I mean, by the way, the prime minister is not listening, so I don't think you need to worry about that. But it's a hypothetical question. It's meant to be hypothetical. Sachit.
Meaningful masking, efficient masking. There are very few non-pharmaceutical, there are no pharmaceutical interventions, honestly, that we have. At this point, given the status of the availability of the vaccines, the bridge to vaccine is to meaningfully get people to distance, sanitize, and mask. And what I mean by meaningful is to take people on board with you. I think the current administration has, for a sustained period of time, despite the ups and downs, has a year of the people, and to use that communication and the pulpit that they have to invest the kinds of resources that they have in interventions like digital contact tracing apps and lockdowns, or this chase for remdesivir, instead to really get people to be 100% compliant with a triple layer mask that covers the nose and the mouth, and to do it in a way that is meaningful in the hot summers of India, to do widespread mask distribution using these war rooms in our state governments.
Thank you, Sachit. Manoj?
Yeah, I would agree with Sachit as the mask and vaccine. I think, the earlier we involve private sector in vaccination, better it would be. Vaccination needs to basically, we just need to accelerate it as much as possible. Put all our money behind that, because, it's not about which vaccine is good or which is not. It's all about, are you getting vaccine or not, right? So we need to vaccine as much or population as quickly. And mask, yes, mask is like, absolutely.
Pawan?
Yeah, I would say, so of course, the points that Sachit and Manoj have made are critical ones, but I would say we also need to understand the existential threat that the pandemic poses, and that threat forces people to engage in behavior that then endangers the rest of the community. So we need to take a broader perspective on this problem. Why are people not following the seemingly simple requirements? And I think in some cases, they have simply not been convinced enough. And in other cases, they don't have the luxury of staying at home when their child is about to pass away. So I think this requires a very difficult and a very broad intervention. And I'm not an economist, so I don't really know exactly what that intervention is, but I think this is an amazingly difficult problem that we are facing.
Vikram, I'll go. Sorry.
Yeah, okay. Rajni, you have the last word. Anand.
Anand.
No, I was just going to say that, I am a firm believer in the fundamentals. And I think the fundamentals is the health system's resilience, which needs to be built in. There needs to be public health intelligence. Decisions through the last year have been often driven by home ministries and sometimes police machinery, and not really by public health folks. We really need public health folks in at times of this to be leading the response. And if that happens and it is actually done transparently with accountability, then I think all of these issues would be better addressed. And I think we have the competence and the expertise available. We perhaps are just not leveraging it enough in the right way.
And Rajni, you get the last word.
Yeah, I agree with everything that the panelists have said. I just wish I could say that what we did last March after the horrible lockdown period was widespread awareness on masking, on distancing. We need to do that tenfold more now, given the variant and its infectiousness. Regarding public health intelligence, and I also agree with Pawan on this whole behavioral thing, people are tired. Health systems providers are tired. And the finances, and I think that's a very important consideration. We'll have to mobilize the money, which is not happening quickly enough, I think. We have to mobilize money so that our workers on the front lines get paid. We have reports coming in from almost every state that ASHAs have not been paid. And that is really unjust and unfair because they have been on the forefront of this battle. So I think we need to go at this the same way we did last year, but with a redoubled or a tripled effort, because it's the basics. It's the mask, as Sachit said, but also then open up the vaccines to people above 18 and to make sure the private sector is controlled and regulated, but to make sure that it's available to everybody. Even now, people in slums and vulnerable areas are not, even women, even individuals over 60 and over 45 who are eligible for the vaccine are not getting it simply because workers are unable to reach them and motivate and mobilize them for the vaccine.
Thank you, Rajni. Well, here's thanking each and every one of you on behalf of the Mittal Institute for having made the time to be with us today, and to all the attendees. I just want to end by, not only endorsing everything that's been said by our panel members regarding what India should be doing in the days and weeks ahead, but I'd like to also re-emphasize some points that were made, which is about having an equity focus in our thinking here. The pandemic is affecting groups in our country in very disproportionate ways. And particularly, we know from the benefit of hindsight that what those groups are, leading at the top of the list of people who are daily wagers. And I think it's deeply, deeply important that the Indian government really takes a leaf out of the tremendous stimulus efforts that many other countries, including finally here in the US, have played to make sure that people don't go hungry because of the impact of the pandemic. It would be such a tragic moment that in saving lives from the infection, we see people dying because of hunger. And that is a clear and present danger right now. And so certainly I would add the issues of the powerless and the poor in India as being at the top of the priority list. Well, with that rather somber ending to this panel, it is a somber moment for India. We cannot pretend otherwise. Let us wish all our friends and colleagues in India all the very best in these next few weeks and months. And we hope from the Mittal Institute's perspective that whatever we can do to support you, please do let us know, and we will try and reach out in whatever way we can that is feasible. Thank you all very much, and have a great day.